All right. All right, I'm going to go ahead and get started here. Looks like we got some more people joining us. So thank you for taking your time tonight to come join us for our Men's Health virtual seminar this evening. My name is Lauren Lavin, and I work as a student assistant at UI Healthcare, and very excited to have Dr. Pearlman and our guest Dennis joining us this evening. You'll hear from our expert, Dr. Pearlman, shortly, but prior to that, I do just have a few housekeeping items to address prior to the program. So the first one is that you will be muted during the program. And also you can use the Q&A button at the bottom of your screen to submit a question at any time during the program. Please note that you can also submit this question anonymously as well. And so this evening, we're going to be answering questions throughout the program, and you're able to submit a question at any time. So we'll address any questions that were pre-submitted as well during the registration process. And then the last thing is closed captioning. So if you need closed captioning, you can go ahead and turn that on at the bottom of your screen. The closed caption button says CC on it. And then after clicking on that CC button, you'll go ahead and click on Live Transcript. And then from there, click on Show Subtitle. And then after that's done, you'll see those subtitles appear at the bottom of your screen. So at this time, I will introduce our presenters for the evening. So presenting this evening is Dr. Amy Pearlman, who is a urologic surgeon and director of the University of Iowa Men's Health Program. Dr. Pearlman will cover the causes of erectile dysfunction and many affordable treatment options available in our hour together this evening. And then also joining us is Dennis Wallace, our guest panelist for this evening. And Dennis will share his personal experience with how treating his sleep apnea, pelvic floor dysfunction, low testosterone, and Peyronie's all came hand in hand in treating his erectile dysfunction. So at this time, I'll go ahead and turn it over to Dr. Pearlman to begin our program this evening.
Awesome. Thank you, Lauren. Amy Pearlman here, urologist and men's health specialist. Hey, Dennis, why don't you say hello to the group? And this mic isn't on, it's just a prop. Dennis, say hello.
I love the mic. How are we all doing tonight? First, if I seem a little nervous, I apologize. This is one of the first times I've been on this side of the webinar, but hopefully we can get some good information to anybody out there that is concerned with their own issues and get you the help you need. Thanks.
Yeah, thanks, Dennis. So my role in tonight's webinar is to answer the pre-submitted questions. I'll be taking a look at the chat box throughout this evening to answer any additional questions that arise. I'll also make sure that we keep on time. We will end this at exactly 7 p.m., if not earlier. I'm also going to engage with Dennis throughout this webinar. And what we'll do is we're going to change up the format a bit compared to our previous ones. For all the nitty-gritty details, you can actually find that on our University of Iowa Men's Health webpage. So tonight we're gonna get rid of the PowerPoint slides, and we're gonna focus on me and Dennis presenting together when it comes to the variety of options that we have to restore sexual function. We're gonna break it up into topics. So after I discuss the basics of each treatment option, I'm gonna ask Dennis to weigh in terms of his experience as a patient, and you'll get my experience as a provider. So feel free to use that chat box to engage with Dennis and I throughout the talk. And then we'll go through some demos, and I have my display of demo products behind me, and picture what is worth, what's the saying, 1,000 words. And we'll use some of those demo products to show you, to give you some advice on how these actually are used when it comes to restoring sexual health. Dennis, before we get into the first option, which are pills, why are you here tonight with us? What is your message to the group when it comes to male-specific health concerns?
Well, Dr. Amy, as you know, I'm about 59, 60 years old now. And over the past 10, 12 years, the erectile dysfunction has caused a lot of significant issues in my life. My sleep apnea did, my diabetes did, and it's all tied together. And it's just, you know, hopefully if somebody out there is having similar issues to what I'm having, that getting the message out to them that some of these things can be taken care of. Growing older doesn't have to be, you know, such a doggy downer as some people would say. We can still live a happy and sexually fulfilled life.
Yeah. Now, Dennis, you and I have been working together for a while now. How did you ask for help? And what is some advice that you have for anyone joining us? How can they ask for help if they're not sure what words to use?
Well, the erectile dysfunction itself started, 10, 12 years ago, and it really wasn't an issue. It was just an occasional blip on the screen. After a few more years, it became more and more common. And I went to my general practitioner and I said, "Hey, doc, what's going on? I lose my erection during sex, and I can't keep it up, basically. What can I do about it?" And we sat and we had a little talk about it. And he said, let me go get you some of these pills that we've got. And at that time, I think Viagra was the number one pill to be given out. And he gave me like 6 of those little blue pills and that, and took them home. And right away, it's like, oh boy, I want to try these. To be honest with you, I didn't like the Viagra as much. It really didn't do much for me. I was expecting, I'm going to pop one of these and boing, I'm going to have a nice big hard erection. No, it wasn't like that. Actually, the flushing and the headaches, some of the side effects that I had, I didn't care for them. A little while later, I went back to my doctor. Like I said, the erectile dysfunction really wasn't all that bad, but it was enough that it was bothersome. When I went back to see him, I said, is there anything else besides this? And he gave me some more pills. These were Levitra. They worked a little bit better. But again, I didn't like them too much. But when he finally gave me some samples of the Cialis, it was like, oh boy, I think I found heaven. It was the golden pill. I was ready to go at a moment's notice for 24 or 36 hours straight. It was great. The drawback at that time, though, was the cost of them. I think at that time they were like $20 a pill, and insurance didn't cover them. So I'd find excuses just to go to my doctor, say, "Hey, doc, got any more samples?" But
Dennis, I'm going to cut in here for a minute and just go through some of the main points when it comes to the oral options. Okay. There are 4 FDA-approved medications for the treatment of erectile dysfunction, like Dennis mentioned: Viagra, Cialis, Levitra, and Stendra. Stendra is the new kid on the block, and whenever you have a new medication on the market, that oftentimes comes with a financial cost. And when you think about all these different medications and how they work in the body, there's no major big benefit of Stendra, but it's more expensive. And so for that reason, I typically don't use that medication with most of my patients. In fact, I've probably only prescribed it once in the last 3 years or so. For the other medications, Levitra and Viagra work very similarly in the body in terms of how long they stay in the body for. And for both of those medications, you want to make sure that you're taking them on an empty stomach, so at least an hour after eating. Not to say it won't work, but especially if you're eating them or taking the medication after a fatty meal, they are less likely to work. Levitra tends to be more expensive compared to Viagra. And so for that reason, if I'm deciding between those two, I'm really going to go with Viagra versus Levitra. So along with Stendra, I'm putting Levitra on the back burner. It really comes down to Viagra and Cialis. So let's simplify that. Viagra is shorter acting, Cialis is longer acting, meaning Viagra can stay in your body for it to work for up to 4 to 6 hours, whereas Cialis, like Dennis mentioned, can work in your body for 24 to 36 hours, so much longer. Now, it doesn't mean that you'll get and maintain an erection for that period of time. It just means it's available in your body for it to work, perhaps for that period of time. Some other differences: Cialis, you don't have to take it on an empty stomach. So it allows there's less timing involved when you take it. But Cialis tends to take a little bit longer to take effect compared to Viagra. For Viagra, we usually counsel patients to take it about 45 minutes to an hour before desired sexual activity. And for Cialis, we usually tell patients to wait a little bit longer, about 2 hours. Now, an attendee asked this question. The other day, I tried a 20 milligram of Cialis 3 hours before, and it didn't work until the next morning. What happened? These medications work differently in everybody. The key to all of the oral medications is that you have to be stimulated for it to take effect. So some people, say, oh, I took Viagra and I was expecting, a great erection and it didn't happen. Well, you have to be stimulated, and that looks different for everyone. So for some people, it might be looking at pictures or looking at their partner or thinking certain thoughts or watching something on TV or a movie. And people are stimulated differently. But that is important. But yeah, in terms of how these medications work in the body, for some people, they last longer or shorter periods of time. They take longer to take effect, or they don't take quite as long. Now, there's no evidence to say that one necessarily works better than another, but clearly that was the case with Dennis. So for Dennis, you said Cialis was heaven for you, right? Cialis worked better than the
others. It was.
Yeah.
Yes.
Yeah. And so for some of our guys, it's just trying one and understanding, is that meeting your quality of life goals? Do you have the level of spontaneity you're looking for? Does it work okay with when you're trying to, to eat food? And then just trying different ones, and that's okay. The other point that you brought up were some of the side effects that you experienced with Viagra. So some of the common side effects of these medications include vision changes, like color vision changes, blurry vision, headache, facial flushing, sinus congestion, heartburn, muscle aches. And just like there's no evidence to say that one works better than another, some people just tolerate one medication better than another. And that might be another reason why we switch from one medication to the next. Now, let's say you have side effects with Viagra and Cialis, and you're trying to figure out which one you should take. Well, because Cialis lasts in your body for a longer period of time, you might find that those side effects stick around for a longer period of time. And that might be a reason that someone decides to take something like Viagra or Levitra over something like Cialis. Dennis, anything you want to add to that?
With the Cialis tadalafil that I take now, I take a 5 milligram daily, and I still get a little stuffiness. I still get the flushing in that, but I'll tolerate it, like you said, and it's acceptable to me because I like what it does for me. I'm ready to go all the time. I love what it does for my libido, my attitude, everything about it. Don't take it away from me.
You bring up some additional great points here. And Cialis is not necessarily a medication I would use to boost someone's libido, but everything is related. And if you can feel confident that you're going to get an erection that's reliable and spontaneous, then of course we would expect that would affect your desire to engage in sexual activity. So, all these things are related, even though we may not use Cialis to treat a low libido. You brought up another great point when it comes to cost, and cost is really important and really drives a lot of the decisions that my patients make in the office. And with medication assistance programs, and sometimes they're built into the system. So you can get some of these medications for cheap through the University of Iowa or through a medication assistance program like GoodRx, and you go to who contracts with large, pharmacies in your local area. And so it's really taken the cost out of it. And at a university setting, unfortunately, I can't offer samples to my patients, although it doesn't stop my patients from asking. But these medications now, a lot of them have been around for a long period of time, especially Viagra. And so you can actually, they're available generic. Viagra and Cialis are available generic. So I think for the low dose daily Cialis, which is like the 5 milligrams for 90 pills, I want to say the cost is like $14 or $15 for a 3-month supply. Now, Dennis takes the low dose of Cialis every day, which means over time, it'll build up in his system because it lasts so long in the body. And that can provide for probably an optimal degree of spontaneity because you don't have to time it based on when you want to have sexual activity. With the following caveat that for some people, the low dose that they take every day may not be quite enough to get a sufficient erection. And because the amount that builds up in your body with that low dose every day will never be quite as high as if you took a high dose, like 20 milligrams on demand. And that's where you can get a little creative, and not to say that all providers in the community will prescribe it this way, but we certainly follow FDA approved indications, but there are other ways that people can sort of mix these medications in a way that works for them. And it's been shown to be safe. So for some of my guys, I'll have them take that low dose of daily Cialis, 5 milligrams every day. And if they need something a little bit in addition to that, they'll take another, additional 5 milligrams of Cialis, perhaps 2 hours before they want to be sexually active. Or maybe they'll take, 20 or 50 milligrams of Viagra on top of that, just for a little extra. And that's okay too. Let's see if there are any additional questions when it comes to the pills here. So great question here. What are your thoughts about consulting with one of the many online prescribers? I think that there is a role for online prescribers. There are things like for Hims and Roman, and certainly those programs offer convenience, and they're anonymous. Where I think they fall short would be in a case like Dennis's, where Dennis is coming in and erectile dysfunction is one of many of his concerns. And, when you see someone through these, clinics online, they just want to sell as much Viagra and Cialis as possible. And they really don't have interest in treating these other things. What I think the message is too of these online programs is it tells men, nobody has to know. We can keep this a secret and you don't have to tell anyone.
Right.
And while I think that can be helpful for some people to get plugged into the medical system, I think overall it sends a bad message. And really the message is we can help, and let's learn how to talk about it in a way that doesn't shame the important men in our lives of seeking help, but encourages them to do so. Dennis, thoughts?
I've looked into, for him or whatever it is, because it kept popping up on Facebook for me. For whatever reason, I had Googled tadalafil. So these things all popped up. And the cost too was a little bit more, well, a lot bit more than what I'm paying through the GoodRx app. Here in Dubuque, the GoodRx app, 5 milligrams, 90-day supply, is costing me just a little over $17. And like I said, when I first started on the pills, they were 20 bucks a pop. When I found GoodRx, because you had recommended it, my prescription was, I think, $37 for 12, 10 milligram tadalafil. So the cost is prohibitive, and it's also something you need to consider. You've known me long enough. I'm not too shy about what I'm going to talk about or anything. So like I said, it is what it is, and talk to your doctor. If you don't like what your doctor's telling you, have him refer you to a urologist or an endocrinologist, someone else that can give you, what you want.
Yeah. And Dennis, one of the things of many that I admire about you is you're an advocate for yourself, and you ask really insightful and thoughtful questions. And what I hope webinars like this do are equip the participants with what questions they should be asking. And, I think one of those points is if you're not getting the answers from whatever provider you're seeing, see someone else. And sometimes that means seeing 5 different people. And certainly I see some, patients in my office who say, I'd like another opinion from someone else. And I always encourage that, because we as healthcare providers have our own way of interpreting the research and the guidelines. And in my practice, a lot of my management is based on what guys like you tell me works for them. Mm-hmm. And then I use that information to, treat other people. And your feedback is certainly important, has made a big difference in how I treat men. Now, some other questions that have been asked: how do these different medications impact a person with coronary artery disease? Great question here, because the number one cause of erectile dysfunction is going to be heart disease. And guess what the number two cause is? Diabetes. It's all about good blood vessel and good nerve function. And diabetes and heart disease, they just, crush both of those. So, even if someone has heart disease, certainly, a lot of those guys are still candidates for any of these therapies. Where it becomes really important is if you're taking a nitrate. So whether it's you're hanging around with some nitroglycerin, a sublingual that you carry in your pocket in case you have chest pain, or if you take a daily medication, something like Imdur. And if you're one of those guys, then it's really, we cannot, there is really no ifs, ands, or buts about it. We can't use the oral medications because it can drastically lower your blood pressure to a very dangerous level. So it's common that we treat men with heart disease, and we oftentimes use these medications. We just have to make sure we look at the other medications our patients are on to make sure that it's safe. Now, another question is any downside to taking 5 milligrams of daily Cialis or on demand with a higher dose? And I would say no, it really, your body will tell you what works for you. Now, I wouldn't go balls to the wall and take high dose Cialis and high dose Viagra. And when you get up at the high doses, then sure, it might increase risk where you get that prolonged erection. But if you're taking a low dose daily, you need some additional on top of that. I've had plenty of patients, and research suggests that it is safe, even though that's used off label. Now, can you use it in conjunction with injections? Another great question. Yes, for some of my patients, I do combine the two. It's a minority of patients, but the pills work via a different pathway than the injections. So if you're not, if high dose pills are not cutting the mustard, then sometimes using some of the pills with a little bit of the injectable medication might get you the results that you're looking for. My concern there, again, if you use too high doses, it can increase your risk for something like priapism, which is that painful prolonged erection that's no bueno. It is no fun, and sometimes can necessitate a trip to the emergency room to get that erection to go down. So you can be a little creative, but there may be some added risk with that. Let's see. All right, let's go on to the next treatment option. We're going to get into the vacuum erection device. There are a lot of vacuum erection devices on the market. I'll show you the one that I have here. This is one product here. It's a battery-powered device. Batteries would go right in there. This product here is by Gesiva Medical. It's a piece of durable medical equipment. I don't get any kickback from the company for recommending this device. I found that, and maybe Dennis, this was your experience when we initially met, when I would recommend a vacuum device, I had a lot of patients that said, well, doc, which one do you recommend? And I didn't know. I didn't know because most of us don't learn about these in residency. And no longer do you need a prescription for these, and Medicare no longer covers these. So it's really, for a lot of people who treat ED, it may or may not be part of their conversation or talk track. And so I work with a pharmacist at New Cara, and we found a product that is a good product. And this one is going to be on the more expensive side. It's about $400. And I'm not saying you have to spend $400 on a product like this. I've heard good things from my patients. At the end of the day, I wouldn't recommend getting the cheapest product on the market, but you probably don't also need the most expensive. This product here, you can use this attachment here to get the tension band on the edge of this device, and then you take this off. You would then put this on the penis, and you use some lubrication to get a good seal. You push this button here, and then it creates a vacuum to actually bring blood into the penis. Now, if you're using this before sexual activity and not just to increase the stretch of the tissue for penile rehab, then you would slide this band off of this device onto the base of the penis. If you just put this on the penis and you take it off, the blood will just go right back in the body afterwards. So if you're using it before sexual activity, you'll need to use that tension band around the base of the penis. Now, there are a lot of different tension bands out there as well. I think they're underutilized in general when it comes to treating erectile dysfunction. For good erections to get good blood flow in and for that blood to stay in the penis, well, one, you just need good blood flow in, but you also need those veins to collapse so the blood doesn't leave the penis. And I have a lot of guys who can get a good erection. It's just those veins start draining too soon. That's where a tension device or a tension band can be helpful. Now, there are different sizes here and there are different tensions. So the trick is finding one, again, that works for you. That's what this is all about, is a little bit of experimenting with different products. And so you have different sizes and different tensions. And this Gesiva medical product comes with 4 that you can try. Again, I don't care where you get the tension bands. I don't care. I don't think Dennis or I care where you get a vacuum pump, but they can be helpful, especially for guys who are no longer getting regular morning or nighttime erections. When you were younger, 19 years old, you know, oftentimes you'd probably get several erections in the middle of the night and not even know about it. And folks, that was your body exercising itself and getting good, well oxygenated blood to that penile tissue. As you get older, and if you have other medical problems, you stop getting that influx of blood to the tissue and the tissue changes. So, you know, obviously our goal is with some of the medications is to get you well oxygenated, good erections. But if you're not, then that's where the vacuum erection device can help get stretch to the tissue. Dennis, you've tried a vacuum device. What is your insight or input on this type of device?
Well, I didn't buy the $400 one. I actually went to Amazon, and the device I bought was $90. It was something very similar. It's battery operated. It also comes with a hand pump in case your batteries die on you. I don't use it with the bands to maintain an erection. I use it for rehab of my penis after the Xiaflex and the Peroni's treatment that I went through. Because you lose some length, you lose some girth. And I use it twice a day, about 6 minutes a day. And I'm regaining girth. I'm regaining some of the length that was lost back then. If I lose some weight, I'm going to regain a little bit more of all that. So it's all good. But yeah, definitely get yourself a pump.
Yeah. So I'm glad that you mentioned that. So you bought a $90 device from Amazon and it works well for you. So that's, you know, that's really great feedback. I'd love to, hey, Dennis, maybe offline you could, or in the chat box, if you remember the brand or the type, if you want to put that in, you know, because I certainly have many patients who are like, I don't want to spend $400 on a device, and that's okay, right? The key here is that you find one that works and you actually use it. And you've just made that part of your routine. You said 6 minutes in the morning and 6 minutes at night, and it's part of your penile rehab program. Dennis, I love it. All right. So let's see if there are any specific questions related to the vacuum pump, and I don't think so. Now, another point too is you can use Cialis and Viagra or injection therapy that we'll talk about next with a vacuum pump. So you can combine all these therapies. And I think that's where we really do a good job of treating men and their sexual function, is we get a little creative with combining some of these things because they all are going to provide a different, slightly different advantage. Okay. So another option here is going to be penile injection therapy. Now, I didn't see Dennis's eyes when I said penile injection therapy, and I can't see anyone else's eyes on this webinar. Now, it's, you know, for the in-person visits, when I'm sitting across from someone and I mention penile injections, the facial expression is really helpful in guiding my management and what I say next. Now, does anyone give me a high five and say, yeah, Pearlman, I'm down. Let's do some penile injections, you know, before sexual activity? I would say probably not. I mean, I can't say for sure, but I don't know that anyone's given me a high five after talking about penile injections. But they do work better than the pills. And I have some guys who love injections, and I have some guys who hate injections, and I have some guys that fall somewhere in the middle. But, you know, the only way to know how well you tolerate it is to try it, to be honest with you. So let me show you exactly what this looks like, and I'll do a little demo here. So you get a vial like this, and I usually use a combination of medications. It's called Trimix, but there are a lot of different formulations out there. You can do a single agent medication Edex, or otherwise called Caverject. The medication is Alprostadil, is the non-brand name. You can do Bimix, which is 2 medications, Trimix, Quadmix, Super Quadmix. You can change what the ingredients of each of these things in terms of each dosage of the medication. And sometimes it gets a little bit overwhelming and complicated. What I find when pharmacies and offices offer like 20 different options for injections, it's oftentimes because they don't offer anything else and they don't want to lose you as a patient. So they're going to try, 10, 20 different things to try to get you good erections before they say there's nothing else to offer. And I think there's a role for that if someone is keen on maximizing injection therapy. But for the most part, I go with Trimix. For the single agent medication, and Dennis, you've had some experience with that single agent medication, it can cause a dull ache in the penis or a pain in the penis. And for some guys, that's enough to say, I'm not interested in doing injections. It kind of, that dull ache can linger on, past the erection. So for something like Trimix, you would get a bunch of needles and syringes like this and a vial like this. And you would start at a very low dose and titrate your way up, usually at home, sometimes in the office, depending on where you're getting therapy. And so I might start someone off at something like 20 units. All right. This is an insulin syringe. If you're someone who has diabetes and you inject yourself with insulin, same type of deal here. You have the penis here. Okay. And the goal here is to inject at 10 or 2 o'clock. So you might inject here. You can see, so here or over here. You don't want to inject right on top of the penis here because that's where you have the dorsal neurovascular bundle. A lot of vessels in that area, a lot of nerves. So not on the top. And you don't want to inject on the bottom part here because that's Mr. Urethra. That's the tube that you urinate out of. The other point too is you don't want to inject towards the tip of the penis, but rather towards the base of the penis. So 10 or 2 o'clock towards the base, you hub the needle in, you slowly inject, take the needle out, hold pressure on the penis for a couple minutes, and then you discard this in something like this, a sharps container, so you don't cause you or anyone else harm. And yeah, you would do these injections before sexual activity. So it's not like you come into the office for a one-time injection and it lasts for all sexual activity there on out. And it doesn't take quite as long to take effect compared to the oral options. For the injectables, you usually do it about 10 to 15 minutes before you want to be sexually active. Some of the downsides to the injections are, if it causes discomfort or pain, some partners may give, their gentleman an injection. And if they feel like they're causing their person pain, that's not really sexy. And it's perhaps hard to get into the mood after doing that if there's any discomfort. The other point too is that one of the medications in Trimix called papaverine can cause scar tissue. And for men like Dennis who were coming to me with scar tissue at baseline that was causing some bothersome penile curvature, I try to stay away from the injectables in guys like that because it can actually worsen scar tissue formation. Dennis, any comments that you would like to make on the injectables?
Well, I know, one of my first appointments down there during the Xiaflex treatment for the Peyronie's, they took my blood pressure, your CMA did, and I've actually got a picture of it. My blood pressure was like 175/95. I thought I was ready to stroke out. I was worried about the shots. Mm-hmm. And I'm not going to lie, you can feel the needle going in, but it was nothing compared to what my mind was telling me. The only thing I did not like about it was either there wasn't enough injected because it only gave me maybe a semi-erection. And then, of course, you had to give another injection to kill that off. And I felt like a pincushion down there. But it was just after the fact, it was uncomfortable. Mm-hmm. There was a dull aching in the whole penis. But I just want to bring something up. I noticed there was a question in the chat. Somebody had asked, the pills had quit working for them and was wondering if he was too young for an implant.
Oh, you want me to answer that question?
Well, I'm not going to tell him he can get one.
Yeah. And I'm going to address some of those questions when I go into a little bit with the
Okay.
But yeah, the reality is, and you bring up a really good point, Dennis, is our national guidelines from the American Urological Association say that any treatment option as a first choice is a viable option. And what we don't like to see, especially people like me who specialize in restoring sexual health, is guys who have been going through this for 2, 5, 10, 15 years, and they're not satisfied, and they're just sort of like strung along this whole process. And, I have some guys who, try the pills, and let's say they have side effects from the pills, even though they work. They'd be a candidate for any one of these other options. Let's say the pills work and the person doesn't have side effects, but they don't want to have to take a pill before sexual activity. That person would also be a candidate for any one of these other options.
Right.
And that's really the answer, is understanding what natural and spontaneous and reliable and good sex means to the person. And that's going to look different for everyone. For some guys, they might say, well, a natural erection is my own blood filling my own penis, right? And for those guys, they're probably not going to be satisfied with a penile implant. Now, if a guy says, I don't want to have to worry about getting a needle out of the freezer and injecting my penis, and a natural erection for me, Dr. Pearlman, is being able to wake up in the middle of the night and roll over to my partner and be able to engage in an intimate activity, So for that guy, yeah, he's probably going to be pretty satisfied with something like a penile implant. So the real answer is, there's no right way to go about it. My goal for patients is to understand, and that's what these webinars are about, is to understand we have so many options to restore sexual function. And it can be overwhelming if you're learning about all these options in one single office visit. Because at the end of the office visit, providers like myself are usually like, so what are you thinking, Mr. Smith? What would you like to do? And it's so rare in medicine that we give our patients the choice. And then if you're not able to have your partner with you, if you have a partner because of COVID, you're looking around being like, I need some guidance here. I don't know. I got to talk about this, see what my partner thinks. And it can become overwhelming. And really, by the time you leave the office, you've probably forgotten 99% of what we say, because it's just too much information. And that's what I hope these webinars do, is sometimes you got to hear this conversation 10 times before you get what I'm saying, and another 10 times before you say, you know what, Dr. Pearlman, I'm thinking about the injections. Let's try that. I would never force the injections on anyone. If someone says, I'm just not interested, fine, let's move on to the next option. But you can combine the injections with something like a vacuum pump. One of the comments from the group was, let's say you're after prostate surgery and you're recovering and you're 6 months out. Well, the key thing there is whether or not, if your prostate was removed for something like prostate cancer, if your surgeon was able to spare your nerves. And if they were unable to spare those nerves that are plastered right on that prostate, then the pills are probably not going to work for you. And the reason is because those pills rely on the release of nitric oxide from those nerves. And if you have no nerves, it doesn't matter how much Viagra or Cialis you take, probably not going to work. And that's where I might skip the pills. If I know you didn't have a nerve-sparing prostatectomy, I might say they're unlikely to work. Let's go to the injections. Let's use something like a vacuum pump to get you erections as soon as possible. I also will say that we're on your timeline, and for some people, they need 6 months or 12 months or 5 years to decide how they want to proceed, and they want to take it slow. And other people are like, I want my erections 5 years ago. Let's do this already, And while it's fine to have your own timeline, I just think it's important for everyone listening to understand that it's the same thing in weights. And if you lift weights and then you just stop lifting weights for 6 months, your body changes. It's not as strong as it was. And it's the same thing for the penis. If you're getting good erections, and then let's say you had prostate surgery or you have diabetes or high blood pressure, and you're not getting good erections for 6 months or 12 months, your tissue changes too. And it may not be the same that it was 6 months to a year ago. And so that's where, doing whatever you can to restore some of that blood flow can be really helpful. Let's see. Let's go on to, we have 20 minutes left. I want to tackle the penile implants here, and then we'll try to address the remaining questions. So unlike that vacuum erection device, the penile implant is a completely concealed device, and you might be looking at this and being like, how does that fit in the body and nobody sees it? It's actually quite remarkable. I have some guys who say, oh my God, the penile implant, it sounds so amazing. It must have just come out. It must be the newest thing to have hit the market. And it's been around for about 50 years. I'm not saying 1-5, Dennis, 50. This came out before all the other therapies. When Viagra came out over 20 years ago, well, medications like Viagra revolutionized the way that we treat erectile dysfunction. But penile implants and subsequent iterations of the penile implants have been around for a long period of time. Now, this guy here, we'll call him, I don't know, Bill. He has a penile implant in. Now, you can't see the reservoir that stores all the fluid, but we'll have the reservoir right here. The reservoir sits in the pelvis for most folks, in between the abdominal wall here and the bladder. And this stores all the fluid, and all this is, it's like a balloon, and this balloon sits inside the body. And so it makes that saline, the normal saline that's inside of that device, body temperature. So neither you nor your partner can tell the difference between body temperature blood and body temperature salty water. The other components of the implant include the cylinders. So really with the implant, we're just replacing the hydraulics of the penis. And the penis has 3 cylinders, 2 erectile bodies, and then that third tube, that Mr. Urethra. And so in the operating room, we measure the size of your erectile bodies, and that's the size implants we put in. We can typically put all components in through a single incision, which we typically put in between the penis and the scrotum. Sometimes we'll do it on top of the penis up here. And we can, miraculously put this pump and the cylinders and the reservoir in through that tiny incision. I think of this device as somewhat being like breast implants. What I find amazing, Dennis, when we think about something like breast implants and penile implants, is I would guess that if you were to ask anybody walking down the street if they have heard of breast implants, I can't think that a single person would say no.
Right.
But if you were to ask most people, have you ever heard of a penile implant? I would venture to say, Dennis, that most people would say no. They have never heard of it, despite the fact it's been around for 50 years. And I think that's a shame. But it goes back to that point that someone had asked about, which is the online prescriber clinics. Nobody's talking about it. And that's why nobody knows about it. And my hope, Dennis, is by doing things like this and you being on here and showing, hey guys, it's okay to talk about it. It's all part of our bodies. It doesn't mean we're any less masculine. It's due to changes in our bodies. My hope is that people will talk about it more. So guys in their 70s aren't coming to me for the first time, and saying they have a problem, right? But, so then this pump here, sorry, I got stuck on a tangent there. You have the pump right here, and this sits in the scrotum, and there's plenty of room in the scrotum. We usually put it in between the 2 testicles. We don't remove testicles for this. And this guy has it in, and you would have no idea. In fact, if this guy, Billy, were in a locker room, and I don't know how men's locker rooms are these days, but let's say it's a communal shower, nobody would know. Tom wouldn't know, Ryan wouldn't know, Dennis wouldn't know that Billy had an implant in, because everything is inside of his body, and it's actually very natural in the flaccid state. So when Billy wants to get an erection, he just pushes this pump here, and he's physically moving fluid from the reservoir through the pump and into the cylinders. And he just keeps doing it until his penis is erect. And then his penis will stay erect for however long he wants. And when he wants it to go down, guess what? There's a second tiny button here that Billy pushes and then squeezes the penis, and all the fluid goes back into the reservoir. So let's talk about pros and cons of something like a penile implant. Pros: if you're looking for a reliable and spontaneous device, penile implant's going to be your jam. If you're worried about the costs of something like injectables, because something like Trimix is not covered by insurance, so you're looking at maybe $150, per vial, which would typically last you about a month, you know, with penile implants, at least in the state of Iowa, we're very lucky, and a lot of commercial insurance companies cover the penile implant. So you're really on the hook for, you know, whatever your deductible is, and then it depends on what your max out of pocket and your co-insurance and things like that. But it is a covered benefit for a lot of insurance companies that we deal with. Medicare covers it. If you have Medicare and a supplement, then usually that supplement insurance policy will cover whatever Medicare covers. Medicaid, state insurance, is the main insurance plan that in Iowa that does not cover the implant. So, you know, I'm hoping that at some point that will change, but that would be a downside to the implant. The implant is a surgery, and there are some, you know, people who are interested in having surgery and others that aren't, and that's okay too. In terms of all the surgeries that we do, it's more on the minimally invasive side. It's one of the more common operations that I do. You know, I do probably 40, 50, 60 penile implants in a year. Some people do 1 or 2, and some people across the country, especially in places like Miami, you know, might do 2, 3, 400 penile implants. But in terms of, you know, surgery for any patient is a big deal for surgeons who specialize in this field. It's kind of like breast implants. You know, you're kind of in and you're out. We do keep most of our patients in overnight. You go home the next day. Procedure itself takes about an hour to an hour and a half. So a lot of, you know, I think I would never force a penile implant on anyone either, just like I wouldn't with the injections. It all depends on the quality of life goals of the person. Now, another comment here from someone in the group says, I'm 43, diabetic, pills used to work, they don't work anymore. Is a penile implant a viable option? The answer is yes. You know, I don't, you know, the age of the man doesn't, you know, necessarily change how I manage someone. Certainly if you're younger and you're getting a penile implant, and I tend to see that in guys who are type 1 diabetics, because they tend to have been diagnosed with diabetes at a young age, and it can be quite difficult to control. Those are the guys where I'm typically putting a penile implant in at a younger age. I have guys all the way in their 80s and 90s. I put a penile implant in someone recently who's like 83 years old. His first question after surgery was, when can I play table tennis again? Right. So that guy's, you can tell he's going to live a long life because he's active. But, you know, I have some guys that say, I'm in my 80s. Am I too old? My response is, if not now, when? You know, so if you're safe enough for surgery and that's what you want, then most of the time, you know, we're okay with it. Dennis, anything you want to add about the penile implant?
Well, on one of my first appointments down there, when you were going over the options with me for the Peyronie's treatment, at that point in my life, it was implant, not going to happen. After sitting on enough of these webinars with you and understanding how it functions and what it could do for me if what I'm doing now goes south and I can no longer get an erection, I think I'd be perfectly okay with having it done.
Yeah. Yeah. And I think you make a good point, Dennis. You know, for most of the guys who see me, I'm going to start with the pills because it's non-invasive and it works for a lot of people, with the caveat that it doesn't work for everyone. And if you have a lot of other things going on, diabetes and high blood pressure and prostate removed for prostate cancer, then and certain medications, you know, medications for depression and anxiety and blood pressure medications. And sometimes when you get your counting fingers on all these different things that are known to cause worsening erections, at some point it's like, okay, the pills probably aren't going to work.
I'm happy right now with everything. You know, you sat there and you've talked about the guys in their 20s having the nocturnal erections or waking up with morning wood. I'm 60 years old and I've got it back.
Awesome.
It's happening.
Yeah. Now, Dennis, we have a few questions and comments here about testosterone and its relationship with erections and prostate health. And we have you on testosterone as well. I think the answer to that is I don't necessarily put guys on testosterone to improve their erections, though I have plenty of guys that I have on testosterone that say my erections are better. What we do know in terms of testosterone and erections is I see some guys who, let's say, took Viagra 5 years ago and it was working great. And then they come in and they say, Dr. Pearlman, Viagra used to work great for me and it's just not cutting the mustard anymore. And my libido is also a little bit low and I feel a little bit tired as well. And in those guys, you know, they have a lot of symptoms of perhaps having low testosterone. We check the testosterone and it's low. For a lot of those guys, if you put them on testosterone therapy, if they're good candidates, they might then respond to Viagra again. It's really difficult to get a good erection when your testosterone level is low. So oftentimes we're using these medications in combination. But you had mentioned too that Cialis for you improved your libido. Everything is related. It's not only a mental health, anxiety, stress, brain problem. It's all of this and all of this and everything in between. Dennis, anything you want to add with regards to testosterone?
Correct. As you know, I was diagnosed with hypogonadism 10, 12 years ago. And when I came to see you, I was on 200 milligrams of testosterone once a month. I could feel great for about 7 days after an injection. After that, I'm back on the couch. I'm done. I'm fried. I'm tired. With what we're doing now, the 200 milligrams once a week, I do 2 injections. I've got the energy now of a 20-year-old. Of course, I'm 60 years old and I have to watch what I'm doing, but I'm feeling great. There are some other side effects, but we're working on those, and I'm doing great on it all.
Mm-hmm. Yeah. The good news with a lot of this stuff, it's a lot of quality of life, things that we work on, which means oftentimes, we're looking at labs, we're looking at PSA, and we're looking at blood counts, but oftentimes it's people like Dennis and I sitting across from each other and me being like, what are you thinking? How do you feel? Where can we improve? Can we take you off any medications? And sometimes it's easy to add medications, and the trickier part can be, what medications don't you need anymore that we can take off, right?
Exactly.
Yeah. All right. Let's see if there are any, let's see. So a lot of questions here that were pre-submitted and added to the chat with regards to ejaculation. And, people, kind of a couple points I want to make here. One is, a man can orgasm and ejaculate without having a rigid erection. So that's possible. The other point too is, when a man orgasms and ejaculates, it is the rhythmic contraction of pelvic floor muscles. And I don't have a male pelvis here, but I have a female pelvis. But you get the point. Look at all the muscles in the pelvic floor. And those muscles have to coordinate together and work well together and be enough relaxed and yet strong enough to force the ejaculate out, right? And you can kind of feel that when you have an orgasm, it's a rhythmic contraction of the pelvic floor muscles. But the ejaculate, which is the fluid that comes out, that can be affected by a variety of different things. If a person had prostate cancer and let's say had radiation or removal of the prostate, then that person will no longer produce an ejaculate, even if he can still have an erection and have an orgasm. Because most of the ejaculate volume actually comes from the prostate and the seminal vesicles. And both of those are removed with a prostate surgery. And those are also radiated with radiation treatment or pelvic radiation. But also part of the prostatectomy is cutting the vas. So you kind of get a vasectomy thrown in there, and for those reasons, because those organs in the pelvis are removed, you're not going to form an ejaculate. Now, there's a difference here between not forming an ejaculate and having retrograde ejaculation. And retrograde ejaculation is when you have the release of this fluid, but instead of going out of the penis, which is what you may be used to, it might go back into the bladder rather than out. And then after, let's say you pee and you urinate, it comes out in the urine, which you may or may not even notice is coming out. It's not dangerous, but for some people, it kind of hinders or has a negative effect on the sexual relationship. For some people, that process of ejaculation is important. For others, not so much. So any procedure that we do on the prostate, whether it's a biopsy, whether it's a resecting prostate tissue, whether it's using the newest and greatest, Urolifts clips or Resume or any of these other therapies, even if they say it doesn't affect ejaculation, in some men it will. And it might be because maybe it induces a pelvic floor dysfunction. And so, Dennis was one of our guys who saw a pelvic floor physical therapist. And I would recommend anybody, actually any man, woman, or child, or anyone on the gender spectrum, see a pelvic floor physical therapist, because your pelvic floor is really important, but it can also help you with any sort of ejaculatory dysfunction. Medications we put people on, especially as urologists, can also cause retrograde ejaculation. Medications like Flomax, right? That opens up that tissue in the prostate. And so that can cause the ejaculate to go back into the bladder rather than outside of the penis. The other thing too is when hormones are off, testosterone, estrogen, things like that, that can also affect orgasm and ejaculation, and perhaps how much ejaculate comes out. The other point too is as people get older, their ejaculate volume changes. And for some people, that ejaculate volume goes down. It's just nobody ever sat you down to tell you that your ejaculate volume would change. So when it happens, you're taken by surprise. So a lot of different reasons there why the ejaculate might change. In terms of libido's quite complicated. And it's oftentimes when it's associated with erectile dysfunction, it's like, what's the chicken, what's the egg? Is it you're not sure if you can get and maintain an erection for a sufficient period of time? So then you're thinking, should I even initiate? What if I can't finish the job? I'm going to be so embarrassed. Versus, you're just not interested, even though you might be attracted to your partner for some reason. You just are not interested in engaging in sexual activity. And so therefore it's hard to get aroused to get an erection. Sometimes it's hard to tease out those things. Certainly low testosterone can be a cause of low libido. And, it's in terms of the research, it's sort of equivocal in terms of whether putting someone on testosterone increases libido. In my experience treating patients, I see plenty of guys who say their libido is much improved on testosterone, but it's not a game changer for everyone. So certainly checking hormones is important. The other point too, and Dennis, we have about 3 minutes left if you want to touch on this, is working with a couples counselor, a sex therapist. And it might be you going in by yourself and talking through some things, and it might be you going in with your partner and talking about some things. I wish, like pelvic floor physical therapy, that all my patients went in to see a couples counselor or a sex therapist. There are so many things and conversations, wow, we never have, and yet we have these incredibly intimate moments with our partners, and we never sit down and say, hey, what feels good for you? I want to tell you what feels good for me. How do we make this work together? Dennis, what has seeing a sex therapist meant for you?
I tell you, when you referred me to one, well, first of all, when I talked to you about it and I told you, with the Peyronie's, I think I'm keeping a lot of this in the back of my head and I'm just not dealing with it. And you said, go see a sex therapist. And I'm thinking, I had no idea truly what a sex therapist was. My mind was off in the dirty end of things, but it wasn't. I sat down with Susan and we talked. We talked about not only my sexuality, my sexual feelings towards my wife or for others, but different things that were stressing me out. Getting that stress out of your mind and away from you, I think actually adds to a stronger libido. And I think it helped me a great deal. Going to the pelvic floor specialist, I went there because I was retaining urine. I was having ejaculatory pain and testicular pain. I learned about muscles I didn't know I existed. And with the help of Beth and with the help of you, I don't get up in the middle of the night and go pee anymore. I was going 3-4 times a night. Of course, I was drinking way too much liquids during the day, but I'm doing great.
Yeah, I think we're going to wrap it up here, but I think, Dennis, the message from both of us is it's never just one thing. It's probably 5 or 10 different contributors, for sexual dysfunction and low libido and low testosterone that we can identify. Probably another 50 that we don't even recognize are contributors. And everything plays a role. And sometimes anxiety and stress are going to play 50% of the reason why an erection isn't going to occur. And other times it might be alcohol or medications or pelvic floor dysfunction or prostate cancer. And the important thing is understanding how to ask the questions, how to advocate for yourself.
Right.
And there's a specialist for everything, right? So for the relationship that you and I have, I treat a few of your concerns. And for the ones where I don't have, the time in my office as a surgeon to sit down with you to talk through some of these other things, that's why I have people like Susan Totten, or Jason Lassner or Aaron Mayer in the community, right? We all have our role in caring for men like you.
Yeah.
So we'll wrap it up here. Lauren, do you want to, go ahead, Dennis.
Just one last thing to the guys sitting out there, that if you're not getting what you feel you deserve from your doctor, ask for a referral. Go find another doctor. Dr. Pearlman was my third urologist, and I hit it on the head with her. The first visit I had down there, there was a little tap on the door. In walks this woman, and she's, "Hi, Mr. Wallace, I'm Dr. Amy Pearlman. How are you today?" I'm very grateful for that. Very grateful.
Thank you, Dennis. And thank you so much for sharing your story tonight. I have no doubt that you sharing your story has impacted many of the men and their partners on this call. Lauren, you want to wrap us up here?
Yeah, absolutely. So thank you, Dr. Pearlman. Thank you, Dennis, so much for joining us this evening. And thank you all for joining us as well for our Men's Health webinar. Hope it was extremely beneficial for you. And we will be reaching out within this next week with more information on contacting Dr. Pearlman here, setting up an appointment if you would like to. And then there will also be a feedback survey. So feel free to share any comments with us from tonight's program. But thank you all for joining us. Stay warm and have a great evening.